Hello, everyone. Welcome to our webinar where we will be reviewing autism in the perioperative care led by Dr. Greta Duncan-Wiebe. I'm Dr. Curtis Choice. I'm the Director of Ambulatory Anesthesia at Montefiore and Albert Einstein School of Medicine. I'm also the Medical Director of the Perioperative Medicine Clinic at Montefiore. And I'm very interested in this topic in particular because we handle this patient population as well in our ambulatory surgery center. So for those of you who are not SAMBA members, please consider joining the society as it offers many benefits to its members. And please visit our website at www.sambahq.org to see the benefits of membership. So we have a few quick housekeeping notes before we get to today's presentation. Please note that this webinar is listen-only mode. In the upper right side of your computer screen, you will see a GoToWebinar control panel. Through this control panel, attendees will have the ability to contact our staff via the chat and question boxes. We will have time for Q&A at the end of the presentation, but please submit your questions throughout so that we can prepare to answer. Now, at this time, I would like to introduce tonight's speaker. So as you already know, our speaker is Dr. Greta Duncan-Wiebe, and Dr. Duncan-Wiebe is an assistant professor of anesthesiology at the University of Nebraska Medical Center. She has served in numerous elected and voluntary leadership positions at Children's Hospital and Medical Center in Omaha, and is currently the medical director of the Children's Outpatient Surgery Center in Omaha, Nebraska. Greta graduated with her BS from Nebraska Wesleyan University. She received her MD from the University of Nebraska College of Medicine, and then attended the Medical College of Wisconsin, where she completed both residency and pediatric fellowship training. She was an attending at the Children's Hospital of Wisconsin for 2 years before being recruited back to Nebraska in 2009. In addition to her paid work, she is the mother of 4 energetic kids, aged 15, 13, 10, and 6, and has been married to her husband, Matt, for 22 years. So over to you, Dr. Duncan-Wiebe.
Thank you for the intro, Dr. Choice. It's an honor to have been asked by Dr. Tobin to present tonight. 5 years ago, I would not have considered myself especially comfortable or knowledgeable caring for autism spectrum disorder patients, although I did it somewhat regularly. However, in 2017, as the medical director of our Children's Outpatient Surgery Center, we were approached by the head child psychologist at our hospital about using our surgery center for a pilot project to improve care for children with autism. A very generous donor in our community had provided seed grant funding specifically to make our hospital more autism friendly. I have grown to love and appreciate these patients, and especially their parents, and the tremendous commitment that they have to providing the best care for their children. So let's get started. So first of all, I have no disclosures. The objectives for tonight's talk. First of all, I will go over the diagnosis and history of autism spectrum disorder, and then we will review the unique anesthetic considerations for patients with autism spectrum disorder. And finally, we will discuss the perioperative management of these patients. So autism was first described by Dr. Leo Kanner, an Austrian-American psychiatrist, in 1943. He described these patients as children with extreme autistic aloneness, delayed echolalia, and anxiously obsessive desire for the maintenance of sameness. Kanner viewed autism as a profound emotional disturbance that does not affect cognition. The DSM-2, published in 1952, defined autism as a psychiatric condition, a form of childhood schizophrenia marked by detachment from reality. During the 1950s and 60s, autism was thought to be rooted in cold and unemotional mothers, dubbed, quote, refrigerator mothers. I can't even imagine the guilt that these women must have faced. The refrigerator mother concept was dispelled in the 60s and 70s as a growing body of work showed that autism has a biological basis and is rooted in brain development. The DSM-3, published in 1980, established autism as its own separate diagnosis and described it as a pervasive developmental disorder, distinct from schizophrenia. The DSM-3 listed specific criteria required for a diagnosis. It defined 3 essential features of autism, all developing before 30 months of age. First of all, these children had to have a lack of interest in people. Also, they needed to show severe impairments in communication and bizarre responses to the environment. The DSM-4, released in 1994 and revised in 2000, was the first edition to categorize autism as a spectrum. This version listed 5 conditions with distinct features. In addition to autism and pervasive developmental disorder, it added Asperger's disorder, which, as we know, is also at the mild end of the spectrum. Childhood disintegrative disorder, characterized by severe developmental reversals and regressions, and Rett syndrome, which affects movement and communication, primarily in girls, were also added. The breakdown mirrored the research hypothesis at that time that autism was rooted in genetics and that each category would ultimately be linked to a set of specific problems and treatments. Throughout the 90s, work was being done on the Human Genome Project. Researchers hoped to identify genes that contributed to autism. After the Human Genome Project was completed in 2003, researchers found hundreds of genes related to autism, but could not link any exclusively to autism. It became clear during this time that finding genetic underpinnings and corresponding treatments for the 5 conditions specified in the DSM-4 would not be possible. Experts decided that it would be best to characterize autism as an all-inclusive diagnosis, ranging from mild to severe. And that is what happened with the DSM-5. This is the first time that autism was classified as a spectrum disorder. There were 2 groups of features: persistent impairment in reciprocal social communication and social interaction, and restricted repetitive patterns of behavior. Next, I'm going to go into some of the data of the prevalence and epidemiology of autism disorder. About 1 in 59 children in the United States has been identified with autism spectrum disorder, according to estimates from the CDC. Autism spectrum disorder is reported to occur in all racial, ethnic, and socioeconomic groups. It is 4 times more common among boys than girls, and studies in Asia, Europe, and North America have identified individuals with autism with an average prevalence between 1 and 2%. About 1 in 6, or 17% of children aged 3 to 17 years were diagnosed with a developmental disability, as reported by parents, during a study period of 2009 to 2017. These included autism, ADHD, blindness, and cerebral palsy, among others. This graph shows the prevalence of autism by geographic area. This is a graph from the CDC, which shows the prevalence broken down by gender. This table shows the prevalence by race or ethnicity. As autism becomes increasingly prevalent, we must also be aware of the comorbid conditions that are commonly seen in these patients. GI issues are 8 times more prevalent in autism than in the general population. And as many as 85% of children with autism also have some form of comorbid psychiatric diagnosis. 35% are taking at least one psychotropic medication. ADHD, anxiety, and depression are the most commonly diagnosed comorbidities, with anxiety and depression being particularly important to watch for in older children as they become more self-aware. These issues can last throughout their lifetime, but may also appear or diminish at different developmental stages. Diagnosis of comorbidities can be challenging because patients with autism spectrum disorder have difficulty recognizing and communicating their symptoms. Additionally, epilepsy affects up to 1/3 of the patients with autism spectrum disorder. Caring for children with autism, as we all know, can be challenging, especially in the ambulatory surgical center environment. Poor or uninformed management of these patients can result in employee injuries, patient injuries, failed procedures, and increased use of sedation or restraints. The healthcare environment is uncomfortable, unfamiliar, and difficult for these patients. It can, due to the sensory differences, including bright lights, crowded rooms, unfamiliar noises, textures of the linens. So these are all things we need to take into consideration. Another thing to consider is what medications these patients might be on. Risperidone can cause hypotension with general anesthesia and be pro-arrhythmic. Clozapine can cause agranulocytosis, hyperthermia, cardiac conduction problems, and hypotension. Psychostimulants can increase the sedative dose requirements. We can see hypertension and arrhythmias. They can lower the seizure threshold and interact with vasopressors. Methylphenidate and halogenated agents may interact to cause significant hypertension. So how do we prepare for these patients preoperatively? The number one thing recommended in the literature and in my experience is that it's very important to identify these patients early. Additionally, training for staff is very important, especially in non-pediatric centers. Parent and caregiver input is very important. Flexible admissions, including reduced wait times, quiet rooms, pre and post-op, and then getting advice from the parents or caregiver for what is helpful to their child and what rewards they respond to, and also what triggers them. And then very, very important is to continue their scheduled behavioral and psych meds the day of surgery. So pre-medication, use of pre-medication is recommended if the parents have had a good experience in the past. I'm sure we all use midazolam on a very regular basis, so very familiar with the dosing. Oral clonidine has also been used. One study used this to sedate for EEGs. It does take a bit to set up, so need to plan ahead in these patients. Dexmedetomidine can also be used in the autistic patient. Ketamine in the form of a ketamine dart or oral ketamine has also been used in autistic patients. However, you need to be very cognizant of the potential negative effects, including emergence phenomenon, disorientation, sensory and perceptual illusions, vivid dreams, nausea and vomiting, nystagmus, and hypersalivation. So for induction, what we do at our center, we discuss the preferences with the parents. The most common case that we perform in children with autism is probably dental procedures. And so most of the parents are not doing this for the first time, so they know what has worked well in the past and what hasn't. Some children and parents prefer the IV placed in pre-op holding due to a mask aversion, while other families prefer an inhalational induction. Again, patient and staff preparation is key. And then we do discuss the use of restraint in these kids and the possible need for it. So the parents are aware that it is a possibility and will be used in the case of safety for their child. So intraoperative management is very important in these patients as it is for any patient, but especially for the autistic patient as they may have an aversion to taking meds in the postoperative period. So effective analgesia, antiemetics, and IV hydration are recommended. Because many refuse oral medications post-op, if not given orally pre-op, dexmedetomidine is a useful consideration intraoperatively to help decrease emergence agitation. Postoperative management, be prepared to deal with agitation. In our center, we do this most often by reuniting the parents with the patient as soon as possible, often before they're fully emerged. Early removal of the IV is also recommended. Again, quiet room with parental presence. It's very important to have a scale on your plan that's a nonverbal assessment of pain so that you can help assess if the patient may be needing more pain medicine. And then also planning for early discharge to home. For dental patients in our center, for example, we often give the Tylenol in pre-op holding and Toradol in the operating room. And that way our nurses can actually have their discharge instructions printed with the next dose of Tylenol and ibuprofen already printed out. So as soon as we bring the parents back at the end of the procedure, they can start preoperative teaching before the child is actually fully awake and the parent is more focused on their child and their condition. Another important consideration in autistic patients is non-pharmacologic management. This includes communication and attitudes, good communications with clear expectations, and just being generally friendly towards these patients and their parents. Individualized care and flexibility is also key. And then the use of supports is very important to consider, including tablets or iPads, special interests, a social story, child life. We have a special actually box of toys at our place for that our autistic kids are that are reserved actually for the autistic kids, because otherwise at our surgery center we mostly have preschool and toddler age toys. So that's also proven very helpful to our care. Next, I'm just going to talk for one slide about autism spectrum disorder in adults. An estimated 2.21% of adults in the United States have autism. This ranged from a low of 1.97 in Louisiana to a high of 2.42 in Massachusetts. The states with the greatest number of adults living with autism included California, Texas, New York, and Florida. Consistent with what's found in children, prevalence is found to be higher in men than in women. Autism does not preclude one from being healthy. However, cognitive and communication differences can complicate identification and management of illnesses unrelated to their autism. Autism is also associated with increased prevalence of several medical conditions, as I already mentioned. And mental health conditions can be more prevalent in autism in adults, including depression, anxiety, and PTSD. So our organization and others have developed projects to preemptively address autism spectrum disorder patients' unique needs and to better provide care in the perioperative period. At our center, parents are interviewed as experts on their children to provide information about specific triggers, calming measures, communication skills, and past healthcare experiences. Using this information, an adaptive care plan is created, which summarizes this and then is placed into our electronic medical record. Then this information is shared with all team members the day of the procedure and helps guide our plan, our anesthetic plan, and perioperative management. So I'm just gonna now go into a little summary of the pilot project that we did at our hospital, and then I'll open it up for questions. So our organization developed a quality improvement project, which called PATCH, which stands for Patient Assistance Team of Children's Hospital. Again, it was aimed at preemptively identifying and addressing the unique needs of patients to improve their perioperative experience at our ambulatory surgery center. They were identified in the electronic medical record as having a diagnosis. Originally, they had to have a diagnosis of autism spectrum disorder in the chart, or it could have been revealed during pre-admission phone calls by our perioperative nurses. Then, a child life specialist at our center made contact with the family prior to the day of the procedure, and if the parents agreed, conducted a standardized interview. The parents were questioned as experts on their children to provide information about specific triggers, calming measures, communication skills, and past healthcare experiences. Again, this was placed in our electronic medical record. So between October 2018 and January 2020, 159 care plans were implemented. There were no failed procedures due to triggered or uncontrolled behavioral issues. 34 patients had parent-reported history of aggression and previous need to be physically restrained or held down for a procedure. Several were so severe that security was asked to remain nearby as an extra safety measure. With the PATCH Adaptive Care Plan, there was zero need for restraint by a staff member. There were no incident reports, calls for security or staff, or family or patient injuries. There's really no magic to achieving these outcomes. It just comes down to an awareness of what a patient's specific triggers are, making adaptive changes to the environment, and using appropriate communication techniques, as well as partnering with parents as regarding the care of their child. Really, mitigating the triggers is the first line, but in healthcare, as we all know, some stressors are unavoidable. So identifying signs of agitation and responding with specific calming techniques has helped to prevent escalation into full-blown meltdowns that can compromise the success of the procedure. So I'm just going to do a quick case study here. This is just a pretend patient named Timmy. In previous anesthetics, he had had significant combative behavior that has required large doses of midazolam, up to 30 milligrams orally, to facilitate safe transport into the MRI scanner. He's had multiple anesthetics beginning at the age of 10 years. At 12 years, he was seen with leg pain for an MRI. Pre-medication for the case was difficult due to problem behaviors. At that time, the anesthesiologist prescribed 20 milligrams of Versed and then followed it with a second 10 milligrams of oral Versed, just to get him into the MRI scanner. He underwent an inhalation induction, but was noted, not surprisingly, to have delayed emergence postoperatively, and then he suffered from nausea that was treated with a scopolamine patch. He had several additional MRI scans over the next 12 months, all requiring these very large doses of oral midazolam. And ultimately, by his 13th birthday, the anesthesiologist had regularly been giving him IM ketamine in addition to the midazolam, just for pre-medication. In November 2018, this patient was identified as a patient for our Adaptive Care Plan pilot program for children on the autism spectrum. The Adaptive Care Plan had identified several ideas to help with his developmentally appropriate care. After discussing the plans with the patient and parents, the decision was made to place an IV preoperatively, which he tolerated very well and was very cooperative for. He then received just 4 milligrams of IV midazolam and was transported calmly to the procedure room for his dental procedure with just hand-holding from his anesthesiologist. The adaptive care plan continued with a smooth induction, emergence, and recovery, including no nausea or vomiting. His parents were so thrilled with his care and the attention given to minimizing his triggers. All of his subsequent anesthetics since starting the patch program have gone smoothly, including a peripheral IV placement each time in pre-op holding, which really, unfortunately, none of us had considered in this patient. So he did very well, and this is one of our many success stories from our program. This next slide is just an example of our adaptive care plan. And this is the what's placed in our electronic medical record. We have a different format actually now that we're in Epic. We previously had been getting Word documents, but it's very specific. As you can see, they have preferred toys, and those are our child life people are very good at trying to have preferred toys available. This particular patient did not like the bed, and so they brought in a play mat for the floor for her to sit on, which really helped. And then they also will have the movies ready that the child might like. And often they have prizes if the child really likes, like for example, this girl likes Band-Aids a lot. So like little prizes along the way, she got a lot of Band-Aids, which is a really easy thing, but often we don't think of it on our own. So in conclusion, adaptive care plans are really effective for autism spectrum disorder patients undergoing outpatient surgical procedures in a freestanding ambulatory surgical center. And our pilot project, the adaptive care plan, really helped guide the whole patient experience from arrival to discharge, allowing for everyone involved to be fluid and adaptive to each patient's unique needs. And really, our basic questionnaire can be adapted to help other facilities provide individualized care. One important feature of our program that I really think helps make it successful is our really fabulous child life specialists that actually came out to our surgery center that's a few miles away from our main hospital, and they really facilitated the interaction between the care providers and the parents and the child, and really set us up for success. But I do think that this whole process is very adaptable to people in other centers, perhaps by identifying a handful of perioperative nurses or other providers who could really serve in that role if child life is not available. So now I'd like to, if anyone has any questions, let me know.
So thank you very much, Dr. Duncan Levy, for this informative presentation. I'm going to check and see in our question box here if we have any questions from the attendees. One of the questions here is, how do patients get referred to your program?
Our patients most often get identified during the pre-op phone call phase, especially at the initial launching of this program. Now we have a lot of the patients identified, and they've expanded actually this program in our center to include the emergency room and the inpatient floors also. So.
Okay, and then another question here is, what does your center do when kids age out of this program?
You know, that's a really good question. I don't know that we have a firm plan at this point. I do know that there are parents who have asked for a printout of their adaptive care plan. As everyone knows, Nebraska is a very rural state, so these patients do receive care at other locations besides our hospital. And so some parents have taken this with them as part of their child's medical record to share with other places. And I would imagine as the patients age out, that would be one of the many steps that we would take, setting them up for success.
Actually, I think you really brought up a good point about the utilization of child life, in caring for these patients. We've actually have experienced that same success, with our program, especially with the adult um, autism patients. How do you coordinate that with child life, especially since it sounds to me like you're in a standalone facility? Is that correct?
That's correct. Our child life people are very proactive, along with our two preoperative screening nurses. These patients are flagged early. We actually get an email that they're coming through and that they have a plan in their chart. So child life really, they do it all almost. It's between the nurses and child life, and they're like always there. It's quite amazing how helpful they are.
And then also, the majority of the patients that we care for are for our dental patients. And, as you know, yeah, they do have some medical comorbidities, but what are your thoughts? I mean, in terms of requiring lab work and, pre-op workup and things like that, like what type of things do you generally, require if those type of patients were to come to your center?
Well, I mean, we're only a pediatric center, so we really, unless they have some bleeding disorder, like a hemophiliac autistic patient or something like that, we don't require any preoperative labs. We do often draw labs though under anesthesia or give flu shots while they're asleep. I guess right now we are requiring a COVID antigen test, even in the
Sure.
autistic patients, but we're not around for that, so I'm not sure how that goes.
No, I think that actually brings up a very good point about the ability to help out with lab draws as well, in these patients, especially if they're already coming in for a different procedures. So, what pre-meds do you commonly use for autism patients?
I would say my go-to, just like with any pediatric patient, I would love, especially like for a dental or a tonsil, for example, I try to give Tylenol and Versed, unless the patient has had an adverse reaction to Versed.
Mhm.
Um, but I mean, I find a surprising number where the preoperative preparation for the patients and actually bringing child life back to the operating room in pre-COVID times, really, we needed less pre-med than we thought. Um,
Right. Yeah, that's a very good point.
When I worked at another a different outpatient surgery center doing both kids and adults, I remember we just default did a ketamine dart on everyone, every delayed autistic adult. And
Right.
I don't know the last time I've done a ketamine dart. So,
Yeah, it is very interesting how our practices have had to adapt, with COVID, and I think sometimes for the better. So that's very interesting.
yeah.
Um, and now, what would you recommend as a starting point for a facility with fewer resources? Like, for example, if they did not have a child life program.
Yeah, I really think that just identifying these patients preoperatively and somehow figuring out how to flag them and doing even a small little interview with their caregiver prior to the day of arrival could go a really long way. And I don't think it has to be the anesthesiologist. I think some script for the preoperative nurses just to know their triggers and if they sound very healthy, I think really shortening their wait time really goes a long way also. Um,
Yeah, I agree. I think that's a very good point. Is propofol okay for? Let me see here. Look at the full. So is propofol okay for induction? That was the question here.
yeah, unless the patient has an identified mitochondrial um, disorder, I often use propofol for induction in even in autistic patients. Yeah.
So, and in the case for some reason, if the patient does become out of control, on emergence, and the IV, is removed, do you then fall back on ketamine, IM ketamine?
Or intranasal dexmedetomidine can also
I see.
work.
I see. So is that also how? Because I saw that you had mentioned dexmedetomidine as a pre-medication. Is that how that's administered, as a pre-med?
That's how we often administer it at our center. Yeah.
I see. And then another question here is, Oh, the question was, how do you administer the dexmedetomidine? So, you said it's done intranasally, is that correct?
Yes, yes. I mean, if you're anticipating a rough emergence, though, I think giving it IV in the operating room is a good idea. Or sometimes we'll extubate and then give like 1 milligram per kilo of propofol IV to sort of chill them out again before we head out to the recovery room.
I think this is actually generating some interest now from the attendees because the next question is, what doses of dexmedetomidine do you routinely give then?
Yeah, I think we usually give like 1 to 2 mics. What have you used, Curtis?
Actually, I've never given it intranasally, so that's why I'm definitely
Yeah,
interested in,
yeah.
in how you did the dosing because we do use it in pediatric patients intraoperatively, right prior to emergence. But I think this is something that I definitely would want to look into,
Yeah,
and maybe this could be something as well that we could apply to some of the adult patients that we have coming through.
right. I personally don't use a lot of dexmedetomidine either. It's more of a rescue drug. Um,
Right.
I I like to go a little narcotic heavy also on these patients because I feel like just waking up sleepier is nice, and there's so many ways to do that. But
And I guess intranasal fentanyl could be an option as well. Um,
right, as a rescue in the PACU, for sure, for
right,
sure.
definitely. Okay. Um, well, I think that's it for the questions, and thank you all for participating in this webinar. The recording of today's webinar will be posted on SAMBA's members only webpage in the near future for all SAMBA members to view. Uh, we will send out a notification to members once registration for next month's webinar is open. And thank you and have a great evening. Good night.